Welcome, everyone. On behalf of the African Global Mental Health Institute, I'm Michelle Durham, psychiatrist and vice chair of education at Boston University School of Medicine. And I'm happy today to be co-moderating our panel discussion with Dr. Banga Chaliza, associate professor, chief specialist, and chair of the Department of Psychiatry at the University of KwaZulu-Natal, and also the president of the South African Society of Psychiatrists. Briefly, the AGMHI's vision is to equip those in Africa and the diaspora with the tools and agency to effectively care for those suffering from mental illness. By fostering relationships, creating accessible training and education programs for both providers and the public, conducting and disseminating culturally relevant research, and identifying stakeholders to advance mental health care in Africa and the diaspora. I'm really pleased today to moderate a discussion with experts in integrating traditional healing into mental health care across the diaspora. We have experts from Ghana, Liberia, to Durban, South Africa, and here in the US. Briefly, Niba Galani is faculty of the African Health Research Institute, professor and head of the Department of Traditional Medicine at the University of KwaZulu-Natal, an adjunct professor at Durban University of Theology, and a visiting scholar at the Athlone Institute of Technology. Alvin Grupe is the Deputy Director, Division of Complementary and Alternative Medicines in the Ministry of Health in the Republic of Liberia. Dr. Lily Poby is a researcher and clinical psychologist, Regional Institute for Population Studies at the University of Ghana. And Dr. Thomas Oden is a psychiatrist, specialist in forensics, integrative mental health, and psychotherapy. And without further ado, we'll briefly start with each one of them giving a brief description of how they're integrating traditional healing into their various settings and to describe their setting a bit. So Niba, I'll start with you.
Thank you, Michelle. I work primarily, when I started this work, at the Nelson Mandela School of Medicine. I'm a biochemist by training. And in the year 2000, we were looking at adding a dimension in the training of our medical students, and that is exposing them to traditional medicine. And that's the journey that started of building relationships with traditional healers. And it led us to, of course, obtaining grants to do research, integrate HIV/AIDS activities into the public health approaches in South Africa. And that journey, of course, increased the confidence that traditional healers had in me and the relationship we had. And I think government even realized that. And so when COVID-19 hit the province of KwaZulu-Natal, I was invited to coordinate a strategy that is beyond the non-pharmacological response that we know, to say there's much more to it. Clearly, we were seeing in our society high levels of anxiety, high levels of stress, especially with the first lockdown in particular, which was a very heavy lockdown, shut down completely. And so the initiative then began to say, how do we bring all the mental health disciplines, psychiatry, psychology, social development, social work, and traditional health practitioners into the response. Clearly, it became obvious that not just the biomedical approaches would work alone. The community in KwaZulu-Natal are embedded in their culture, they're embedded in their traditions. And so there needed to be those interventions that allow the cultural approaches to be integrated, spiritual approaches to be included, such that people then can have the freedom to access whichever of the services. In it being led by government, it then makes that the process becomes acceptable to the society, to the population, to the communities at large. And I think traditional healers felt they were being acknowledged in terms of their role in their society. They were quite welcoming to be integrated in the response. we come from a history of traditional medicine being seen as a taboo in our society. So COVID became a very strategic intervention to begin for government and society to begin to realize that they are being treasured and their role is much more important. And even just the culture of the people is being embraced in this society. So it was an exciting initiative. Of course, it's ongoing because COVID is not gone. What changed is just the levels of shutdown. They've been reduced much more. Thank you.
Thank you. Sorry, I need to get myself off mute. Next, we'll have Alvin Grube tell us a little bit about his context.
Well, thank you. Are you guys being clear? Okay, so thank you so much. I'm Alvin Grube. Again, I work with the Ministry of Health, specifically the Department or Division of Complementary Medicine as the Deputy Director. And what we're actually involved with is regulating herbal medicine practice or traditional medicine practice. And I must tell you for fact that traditional healing effort has been recognized. This has been part of the advent of Western medicine. Traditional healers have been here for faith-based, spiritual healers. All these people they have been around, and there have been lots of success. But in contemporary time, we want to upgrade it, take it to another level where there can be documentation, and so to see how we can even improve it for the purpose of research and make it better, make it available. So the Division of Complementary Medicine, we are involved into training of these people to make sure that they understand how to work with other practitioners. Because for us here, the basic term we use, we say promoting, enhancing collaboration, because we want to promote collaboration between traditional healers and Western practitioners. Though there are some perceptions, some challenges that are serving as or gap between, let's say, gap. But we are working on that to see how we can bridge that gap to ensure that it can be fully incorporated, and so the patients can get better outcomes. All what we are doing, the essence is to improve patient outcome. Once the patient can get better outcome, while it's more than collaborating. So yes, basically that's what we are focused on and want to take it to another level. And so I'm excited to be part of this unique platform discussing such issues. So thank you very much.
Thank you very much. And I'm sure we'll ask you a few more questions as we move across, but I'll let Dr. Lily Poby give us a little bit about her context as well.
Okay, thanks, Michelle, and hello to everybody. I'm also really glad to be here to talk a little bit about what happens here in Ghana with regards to integrating traditional medicine. Just a little bit of background. Ghana passed a new mental health law in 2012 after months, years actually, maybe almost about a decade or so of trying to argue and fight and strengthen what kinds of mental health care was available in the country. And one of the great things about the new law was that there was a dedicated portion of it about how to work together with non-biomedical practitioners, so traditional healers, other complementary service providers. They are a big part of the health system, even though they were not formally recognized within mental health space. There was some regulation of their practice, but it was more focused on other kinds of conditions. But with the new law, the new mental health law, which was passed, more concerted efforts are being made to integrate or to work together, to collaborate with traditional and faith-based healers, which is also another category of people that are quite popular here in Ghana. There are lots of Christian and Muslim faith-based healers who do work in mental health care. So the law makes provisions for health workers to form or to negotiate relationships with traditional and faith healers. And in doing that, they actually end up forming the big core of what community mental health care has been like for the last few years. community health workers have been dispatched to most of the communities in the country, and they are actively building collaborations with various herbalists and traditional healers, diviners, faith healers, and all of that within these different communities. Many people in those kinds of communities go to faith-based healers or traditional healers to seek care. So the community mental health workers are going into these communities, finding these healers, and then starting to partner with them in providing the care. We were able to see that in some of the work. I've been involved in a few projects that have looked at the work of traditional healing in Ghana. And in particular, the more recent one, which is called the Together for Mental Health Project, where we are actually looking at how this collaboration is working. How is it being established? How are they able to work together, these two groups of people? And so we're seeing how the community mental health workers are able to provide care within these traditional healing settings, where they encourage the use of even biomedical treatments, in addition to the so-called spiritualized kinds of care and things like that. They are also involved in, negotiating better conditions of services in some areas, or just finding ways to partner together with community leaders to make sure that people who are seeking interventions would be able to reach the interventions that they find most suitable. What has also been useful from what they've told us is that sometimes these communities are hard to reach, and so partnering with these traditional healers has been useful in case finding, in follow-ups, in reviews, and things like that. So it's gradually becoming more of a two-way partnership, whereas in the past it used to be more about finding ways to make sure that traditional healers do things the way the biomedical space would think about it. But we're seeing it slowly also transform into more of a two-way partnerships, where there are benefits to the healers, but there are also benefits to the biomedical setting. And so those are some of the things we started to look at. It's working in a number of communities already, but there are also still a few that still need to sort of patch them up to make sure that community mental health care is more accessible. Mainly because we have a dire need, or a very limited number of biomedically trained professionals. So it's been really useful to see how we are partnering with those who are not formally trained, so to speak, so that we can provide more access to mental health services across the country. So I think I'll end it here, and maybe some questions will bring up other things. Thank you.
Thank you so much. I think we will have a few more questions for you, Lily. And then last but not least, Dr. Thomas Oden.
Hi, everyone. It's very happy to be here. So my name is Thomas Oden. I'm from New Orleans. I practice adult and forensic psychiatry. I'm adjunct professor at Morehouse School of Medicine. Oftentimes throughout the year, I will engage in telemedicine while also working at inpatient psychiatric hospitals and offering consult liaison work. I have a private practice located in Atlanta, although I have patients spanning in different states. I distinguish my practice different from a traditional psychiatric practice by offering a service called Reiki, which is an energy healing technique in which you place your hands on someone. You're sending universal life force energy. This was a technique that was developed in Japan in the 1920s. Now, my interest in that, we can go into that maybe at a later time, but being from New Orleans, I do come from a family maternal side for at least 3 generations that practice intuition very openly and honestly within the family structure. Wasn't the epicenter of my life, but very used to hearing people that had a more traditional viewpoint of spirit, and having a background in which that was discussed, but not a big part of my life. Wasn't until medical training where I noticed this. I started to observe that I felt patients' experiences and their emotions like as if it was my own, and it was an intuition thing. Wasn't really discussed with anyone, didn't really feel the need to, but as I further entered psychiatry training, I began to have a deeper interest in understanding that, which kind of led to traveling, really learning about Reiki and working with different traditional healers over time in between different job contracts. And by the time I was finished with really perceiving that and integrating that into my life, I decided to have a private practice in which I would allow a space for that to take place, where people can openly discuss their cultural background and how they may perceive what's going on with their minds and their bodies, and actually introducing a concept of spirit involved in it and holding space for that. And so in my practice, I do engage in Reiki, which, you know, discusses the biofield. It goes over the chakra, and it doesn't replace standard traditional psychiatric medicine. It just offers an overlap. And so it's just allows an opportunity for further conversation, more empowerment. I work with traditional healers that may want to, you know, discuss the patient's care and engage in that conversation, because many people will engage in other types of practices and they don't feel comfortable bringing it into a doctor's office. And so I like to open up a space for that. And that's really a big part of practice by offering herbal medicine options. I'm a big believer in psychopharmacology, but it does seem like oftentimes a combination of herbal treatments with prescriptions can be very effective if you're sensitive to medications. Also, we'll throw Reiki into the mix and just allow for that conversation to take place for people who are open for that. And, you know, if I see patients that would benefit from talking to an acupuncturist, I will give them information regarding that. I'll try to refer them out to different services that they would benefit from. And I'll end there.
Sure. Thank you so much, Dr. Odin. Thank you so much to the panelists. So maybe I'll just start by, I've got some questions for each of the panelists, and I'll probably just, for the sake of order, I'm going to start the way that everyone has started. So Neba, can I start with you, Dr. Kalini? Can you tell us a little bit more? I think you glossed over it too quickly, but can you tell us a little bit more about your lab, your traditional medicine laboratory? Perhaps a little bit about the students that you've kind of graduated with their masters and PhDs from there, and your collaboration with the traditional healers in that regard. Thanks.
Okay, thanks. I thought I was going to just talk about mental health. Yes, in this journey, we were able to, I started this work being a deputy dean at the medical school, but by the year 2007, the demand for this work grew such that I resigned, and I applied for a research chair position, which through that we were then able to set up a lab, and we've on an average year we probably have about 20 students at a time, masters and PhDs and postdocs. Now, we never started looking for the herbs and medicines for the healers, but it came out of the relationship of trust, that they would then come and say, look, we have this product, we would like you to evaluate for us for HIV, for cancer, for diabetes. So that is the work we do. We have made a very clear call to young traditional healers who have received formal education to say, please come and join us. And you can pursue masters and PhDs and become leaders, because I'm not a traditional healer myself, though I have passion for this work, but I do not have insight into how the disciplines would grow. So I have a first Sangoma, who is just completing her PhD now. She had her master's and completing her PhD. I have a few herbalists who are lining up to join. And so that's part of what we would like to see, such that we can also operate in the space of the clinical side of traditional healing, not just the laboratory. But it's easier to work with people you've worked with, you've developed, and the systems that they understand. And so that's been the beauty of this journey. And so you learn every time in the process, and it's great to see. Thanks.
Yeah, thank you so much, Neba. I think that was also important. I presume then that means you are trying to create a bit of an evidence base for some of the herbs and some of the healing practices that the traditional healers are using.
Oh yes. From the philosophical side, I mean, we're just about to release a book that's discussing the theoretical foundations of our African the Nguni side of African traditional medicine, because it's got its history, it's got its foundations. It's not just in the air, as sometimes people think. It's just that it's not conceptualized in the kind of biomedical Western way, and that's the main difference. The second is the fact that we've been fortunate that there's been a lot of focus on the training itself, because it's equally is not documented, yet it's rigorous as you're training a medical practitioner. It's grounding, so we've been publishing in that space, and one of the reasons for doing so is the fact that there is a perception, because it's not formal education. It's I don't know what's, it's like, it's gobbledygook. It's just something people
it's like
undermine.
apprenticeship training, isn't it?
Yeah.
Which is very similar to medicine, actually.
It's very, yeah. So that's the part of what is coming up to say, and in South Africa, there is a move that traditional healers can now be registered as professionals, but there's a need for their indigenous knowledge approach of education to equally find a way within the national qualification framework of South Africa, such that they can equally be accredited. So we're finding our research now contributing to that policy discussion in South Africa, including, of course, the fact that we want to create this evidence base for the practice and the herbs. Yes.
Thank you so much, Dr. Koleni. Lily, as a clinical psychologist, I was really interested in your Together for Mental Health project. I was just wondering about, in that work, what happens if you find perhaps practices that leads to ethical dilemmas for your people? So as you've mentioned in the past, and you've written about this, when you find people that have been chained up, for example, at churches or at faith healers' homes, how do you negotiate those ethical dilemmas?
Yeah. Yes, thanks for that, Kwanga. It really is a very major component of the work that we realized the community mental health workers had to deal with. These ethical dilemmas of seeing the things that are going wrong, and yet having very little resources to actually to be firm about applying the law. As I mentioned, there are very few biomedical facilities in the country which can take care of all of the needs, the mental health needs across the country. There are small community mental health units and even regional psychiatric wings at the hospitals and things like that. But they're in no way enough to take care of all of those needs. So we found that the mental health workers who collaborate with these healers are finding very interesting and unique ways of negotiating for the releasing of those chains. They talk about what they can do so that the chains are no longer necessary, and they're really careful about managing their relationships so that it isn't about they constantly said we are not there to condemn them because they are doing something that they think is helpful or that they think is right. So we need to make sure that the patients are protected, and in making sure that they're protected, it means they carefully negotiate to get the chains off by helping with family, sometimes talking to the family members to intervene, sometimes talking to the healers themselves, sometimes providing medication and all of that. All of those things are happening, but in subtle ways. And that's one of the big challenges that we identify, particularly in that project, the Together for Mental Health project, that the law has been passed. Yes, these things are going on, but there's still very limited resources that helps the community health workers to actually do their work appropriately. So it's through negotiations, it's through discussions that they're helping people to get out of those chains. They're starting to do education and as well of families, of healers and other carers to talk about alternative ways of restraint or of approaching let's say, aggressive behavior and things like that. It's painstaking, it's sometimes tedious, but it's also something that they've started to see results on, and so they are reporting that it's happening less and less. So hopefully, eventually to be a thing of the past. But we're also really conscious of the fact that in a lot of ways, what ends up happening is that we may be exchanging one form of restraint for another, because they're prescribing medications and things like that, which may equally be restrictive in that sense. So like I said, there's still a lot that needs to be figured out. Resources in terms of, for instance, clinical psychology is very scarce still. There are not many clinical psychologists. There are not many social workers in these communities. And so you'll find the community health workers having to play all of these roles sometimes. So it's about negotiation. It's about discussions and education of the people working with.
Dr. Kobi, I think I lost you a little bit at the end, but I think we got the gist of what you're trying to say.
Sorry.
So it's okay. It's okay.
Yeah, okay.
Dr. Oden, if I can move to you as a clinician, I was really interested in this, and I wanted to ask you a little bit more about how do you, when a client comes to you, and you kind of mentioned that sometimes you feel that the client kind of requires non-biomedical sort of interventions. So how do you negotiate that space with the client to say to them, as a practitioner of multiple different types of healing expertise or whatever, I do, Reiki and other things. I was just wondering a little bit about that interaction at the beginning with your clients.
Right. So I'll first say that it's very different from patient to patient. I will wait until someone has more stability psychiatrically before engaging in different types of techniques. If you're in a moment of intense crisis, you're in a moment of psychosis or mania, I will not add those methodologies yet into the conversation, because I know what works and what works more efficiently through psychopharm. But I'll just really start with the psychiatric assessment, because that's a centerpiece of just the work that I do. But I also leave room where the cultural aspects of how someone is perceiving what's going on, getting a better idea about their physical health, their dietary health, while also getting a sense of just their foundation when it comes to their spirituality. And then from there, once I have an understanding of how they're seeing what's going on, particularly if they've spent time, and most of the patients that I have worked with have spent time working with traditional healers, have tried different types of techniques and gained information there, but still found themselves falling short to where they wanted to be when it came to their emotional health. And finally, reluctantly coming to see me as a psychiatrist, but being more open to it, because they know that I'm not going to scoff at the fact that you saw someone to do body work for emotional healing, or you went through this technique or that technique, or you tried ayahuasca, and they know that it's a space where I can engage in that conversation. Haven't learned about everything that they may have experienced, but know someone who has, or taken some time to read about it enough to see how people have approached that. And so after getting a sense of that, then I'll try to develop a treatment plan that really acknowledges that. I use Reiki as a centerpiece because it's not exact. You don't have to be part of any religion to actually practice the technique. It does provide insights on different areas of the body that may have certain energetic blockages within the meridian system. And so it does get into chi, it does get into meridians, it does get into, chakras, but overall it's meant to just enhance the conversation, to tease out what could possibly else be going on. And so I've noticed that people don't exactly like the DSM. No one really likes having these diagnoses. The terms themselves bring up different emotions. It has a certain weight to them. And that's just, the stigma related to mental health in general. And I use it as a tool. It's very important to just be able to classify what's going on. But I've just noticed that, people want to have a more in-depth understanding. Usually there is a story behind any type of illness, which is one of the most fascinating parts of psychiatry for me, is that you could have 3 people with depression, and within the hour and a half, and they all have a different story behind it. They all have different triggers behind it. They all have different ways that it means, what it means to them and how they've interacted in the world. And so as I, continue to grow as a physician and take on that space as a healer, you realize that the more tools you have available, you're able to just engage patients with different entry points of conversation and recommendations. And so I try to really leave it to a place where they will have an understanding that, okay, this is one out of many aspects of how you're likely going to improve in your life and get the things that you're trying to achieve in your healthcare, but also trying to just have that conversation in a way to where people feel understood, they feel heard, and they understand what treatment options are available, while also working with someone that, hey, well, we can try this other stuff, but if you're not sleeping well, the next few days, we're going here with a prescription. And so that's really, they feel very safe with that, because they know that ultimately I know what works, I know what's been defined in our studies, and I'm going to do that if we need to.
Yeah, good. Thank you so much. And so the last question to Alvin, Michelle, and then I'll hand over back to you. Alvin, I was really impressed and intrigued by the fact that you have a ministry in your country, a ministry of, is it a ministry or a division of complementary and alternative medicines? And so I wanted to ask you, does that mean that it's all the legislative processes in Liberia have now been sorted out, and there's legislation to guide the different healers? And what's that been like, that process of doing that? And I presume that there's now councils for the different healers, etc., in your country.
Yes, actually, the division of complementary medicine it came existence as a result of an act from the legislature rather, and so it has been existing since 1989, and given the responsibility to regulate traditional medicine practice. But have 1989 between there, I was so somewhere between there. So, but it has been existing. We've been working with traditional healers on all angles, but their activities actually is not much information on them. And recently, that was about 11 years ago, the Ministry of Health. We actually work under the Ministry of Health as a division on the Department of Health Safety. And so our first mental health policy and strategy was adopted in 2009. That was 12 years ago. And so in that, certain things were identified or recognized. First, the gap in practitioner. We don't have many practitioners, mental health practitioners or specialists in that area. We have two specialist psychiatrists, and then we have one mental health care center. It's not even a full hospital. So they also identify the manpower gap and then also treatment gap. Now, having these things, they came out to understand that to solve all of these issues, mental health illness have been treated by traditional healers in the past, and they are still doing it, though it's undocumented. So they decided that bringing these people on board or refining their practice would help bridge this gap. Since then, the ideas pop up. The policy has expired. 2016 new one was adopted, and fortunately for us this year, we just over this less than a year in the department. This year, the ministry will be revising the policy. The 2016-2021, just we in the expiring or last days. So fortunately for us, once we're trying to improve it, we're going to insert the portion to promote the division of complementary medicine, effort in promoting traditional healer, being heavily involved into or collaborating with Western medicine practitioners. And also, like a few days ago, I spoke with the guy who is a head of the mental health division. Because we also have mental health division, and we have the division of complementary medicine. So the mental health, maybe people from the complementary division, we should be able to get training for mental health specifically, so that we can know what they do, and they too can get some training from our end, and then we can collaborate. Imagine at administrative level, we are collaborating. Then we can go forward by like training the traditional healer, and then bringing them on table along with the Western practitioner. Because generally there are some perception you have to deal with, some perception and challenges. Well, the traditional medicine practitioner, they perceive the Western medicine practitioner to dislike their practice. They don't believe in them. So that thinking alone, and also they believe that Western practitioners do not reciprocate when it comes to maybe referral. So these are issues that have to be dealt with. And there are some genuine concern or issue raised by Western practitioners. They, they look at the treatment methodology of the traditional healer, not to be systematic. In fact, documentation is an issue. Like we have recent training where I was asking some of those practitioners, this was first of its kind to have full training for the division to offer full training for people practicing traditional medicine. And then asked, whether do you document? He said, no. If you can't document, how do you have record of what you're doing and how do we promote, or even in case of referral, how do you refer patient to the next person if you don't have any document? So they also have the issue of even categorizing the specific type of mental health, categorizing the type of mental illness that they treat. They do it, but they don't even know the type they are treating. So if they can be empowered to be able to categorize them, understand diagnostic, not specifically to give them diagnostic tools, but when there is collaboration where someone comes from, a patient comes from a Western practitioner, he comes with the diagnosis, and the man who the traditional healer understand the diagnosis and say, this is specific mental illness that I'm dealing with. And after that, he can document. I think that also it will be a step forward. It will promote research because, and we are very, very keen on that. We are promoting that. And so that's how we see it, to bring the two people on the table so that they can understand each other. Because to deal with perception, communication has to be strongly involved for people to understand each other. Western practitioners don't understand the traditional healer. Traditional healer, for them, they are willing. They express strong willingness to work with Western practitioners. In fact, when you ask some of them, they say, when you say, if you are sick, do you prefer going to traditional healer or the Western practitioner? They say, I want to go to. So they believe in it also, they themselves, but they want to work together. Some of them are yearning for training, they are yearning for collaboration and referral. And it's a fact, there are some issues that Western practitioners sometimes they feel. I'm a pharmacist in the toxicology. At some point in time, I used to have this thinking, oh yes, their practice is not standard, medication, toxicity, and all that stuff. But now I found myself in a situation where I'm regulating and I'm almost playing a twin model role to see how I can bring these people to their practice on par to collaborate with the Western or the Western practitioner. So it's quite interesting, and sometimes I laugh about what I do. So our division, that's what we are involved with, is legal, and we are under the Ministry of.
Thank you so much, Alvin, and to all the panelists. There are several questions that have come in through the Q&A, so I'll try to direct them, but some of them are for all of you as well, that anyone could probably answer. But I'll start with NEBA. They asked specifically of thinking about specific policies in place in South Africa in particular that regulate the interaction between the traditional health practitioners and the public healthcare system.
At the moment, no. What we have is the regulation for traditional healers as a practice as part of recognizing them. And there's a phase now of developing there's first was legislation, and now there's a process of developing a policy for South Africa for traditional medicine, which will then speak to these aspects. Yet, at the ministerial level, the Deputy Minister of Health in South Africa chairs a committee where all these professions sit together. The medical, pharmacy, nursing, all of those, they sit together and discuss. And part of this discussion, as far as I reckon, was a sense of, at some stage, there needs to be an amendment of the scope of practice for these professions to allow for this bi-directional referral. The traditional healers are keen on referral, and there's a sense that equally the Western trained can be referred. Those are discussions. I'm not sure where that is now. And so, but there's no formal policy that is in place. However, you find in the workplaces, especially in the mines, where there's strong unions who've been advocating for employees to access traditional health services. So they had developed policies. They are more workplace related. Each company at different stages of that. But there's been a kind of a strong move driven by workers for access to traditional health services. Thanks.
Thank you. And this is probably all of you could, but I'll direct this to Lily initially, of thinking about in your local context, some of the traditional healing practices, and do you think with modifications, they could be practiced in other countries or other sites with other people? So how some of the traditional healing practices where you are, other countries could utilize, or other groups of people?
I don't know whether I'm the best person to answer that because I don't have expertise in the practice, the traditional practices per se. But what I do know about them, particularly the traditional healing, the divining and all of that, it is very much steeped in the cultural understandings of illness and wellness and the function of those kinds of illness and wellnesses. I would imagine that it may be useful if the other person believes as well, if other people they agree with those kinds of beliefs or those kinds of meanings. In terms of the herbal, perhaps, yeah, if we can actually do more work to look at the specific benefits or the specific components of herbal medications that are used traditionally, then I think those will be translatable across different contexts. But for the more spiritual kinds of conditions, I mean, I've spoken to some healers who do say that they get foreign patients. People come from other countries to come and see them for healing. So in that sense, I suppose it is possible. But I do not know. We don't understand enough about what their work entails yet to be able to recommend it in that way. A lot of the divining work or the spiritual work is very much shrouded in secrecy and mysticism and things like that. And so if you're not the practitioner or an apprentice of the practitioner, you may not be able to understand so much of the nitty-gritties of what goes into it. But they do say that they heal people, not just who are, let's say, Ghanaian, but they've healed people from other countries. They mention all sorts of countries. I guess my answer is that maybe I'm not the best person. I'm not the best person to say whether we can use the spiritualized kind of care, because I don't understand enough of it, at least in the Ghanaian context. Yeah.
No problem. Alvin,
yes.
Oh.
Yeah. I would say yes, because healing has linked with cultural belief. And once the society accepts you, it can allow you to carry on your practice. I give you an example. In Liberia here, we have traditional healers from other West African countries that are here, like in Ghana, Senegal, Burkina Faso. They are here, they are practicing. So, but before they practice, sometimes they settle in the community, and when they are accepted, they can be able to practice. And I tell you that practice is mainly in the suburb of the city or in rural area. In central town, sometimes we say there are so much educated people, the way they think. So they are not easily accepted in middle town. So they go in the suburb, there where people accept them. But again, the reason could be the level of education. The level of education it has, it can be factored in. So yes, it can be. Depending the community you find yourself, once you are accepted, you can practice there. Because I know of many of the engineers are here practicing. In fact, we give them permission. You come, we assess your skill of practice, what you want to do, what you can do, and then if you permit, we'll monitor your activity, we'll tell you what to do and what not to do. And so yes, but I don't know how other African countries are doing it. How do they accept it? But for us here, I think it is happening because I see aliens that are using traditional medicine here. Yeah.
My answer is yes. We are very common in Africa. We're very common. Sometimes we think we're too different, and our roots are the same. Our culture, we may have different languages, but the center core of it, you'll find that it's the same. A herbalist in Ghana, a herbalist in South Africa, a herbalist in East Africa. There's not much differences. As well as in training. Some South Africans would go to Mozambique, to Zimbabwe, to Malawi, to different parts for training and access to medicines. So it's just that each country develops its own legislation and policies probably differently. However, we are getting into now the free trade zone. Africa is establishing this African free trade zone, which is going to increase trade between countries, and I'm sure even professional services. So the African standards, the African Regulatory Standards Organization is busy now harmonizing. I'm serving in the technical committee, busy harmonizing standards for traditional medicines across the continent. We've got many countries represented there, from cultivation, from collecting in the wild, the quality, to clinical trials, to efficacy. So there's that already in the making. Then the WHO African Regional Office is equally working around these things, such that there is a policy and a regulatory framework that cuts across the countries, such that even the medicines, especially that are proprietary, can be regulated in the same level of standard. So there is that is happening in the continent, harmonizing the way we work and the relationships. And you always find there's not much difference that you found.
Thomas, were you going to say something as well?
Yeah, definitely. I feel like the answer is yes. I'm a living testament to that. You know, being an African-American man who's a Reiki master from a healing technique that came from Japan in the 1920s, you know, like I never thought I would have exposure to that. I didn't have any reference point to that, but here I am practicing this technique. And so I feel like when, you want things more quantified, right? That's very important in the field of science. And that's why you have the National Center of Complementary Integrative Health to try to get more data so that people can have trust in these situations or these types of techniques. But they span so far in history that, I do believe that many people internally are called to receiving certain types of treatment or medicine or approaches. And the more exposure and access you have, the more you're able to utilize that to integrate that in your life. So in addition to Reiki, to speak about things personal, I work with a Babalao. So occasionally I will involve myself in getting divinations and Idafa and making Igbo, and those are things that have helped me. I find many African traditions of how they perceive consciousness very fascinating. That was an entry point for me in majoring in psychology in undergrad to going into psychiatry. I felt that consciousness and the mind and behavior was definitely uncharted territory. And so when I had an opportunity finishing my Western education and realizing that many other areas of the world, practice seeing the mind differently, I was very fascinated in that and very interested in that. And so, that allowed opportunities for the concept of divination to be part of my life and using that to assist me in my own personal healing journey, but also seeing other people get interested in that as well over time by having exposure to it. So I do believe that the more exposure that we receive, and I think that's been enhanced by social media and technology, that you are getting opportunity to learn from people who are thousands of miles away and able to take classes from them as well. And so, I think there's a lot of room, especially within physicians. We've had a very long history of having worse mental health outcomes compared to the general population. And I think that as we continue to fill the demands of our work, and we continue to get bogged down with different things and different aspects of our work and how that affects us from a mental health perspective, I think that we also would benefit from understanding how other people, other healers from spanning generations, how do they deal with the work? Because clearly we haven't figured it out fully yet. And so, I think if you take that approach, it allows more opportunity to see what's really out there.
Thank you. So I want to go and think a little bit about the the power dynamic potentially between the traditional healers and all the folks like you, and how does that power dynamic play out? What have you seen in your spaces, and how do you navigate that? So Lily, I see you nodding, so maybe you can take a stab at that, but I'm sure each one of you could probably answer that in your own way.
Yeah, okay. Yes, you're absolutely right. There is a power dynamic that is actually really clear, drawing from colonial histories, I suppose, in countries like ours. Traditional medicine has always been considered wrong, considered primitive, considered backwards, and actually very essentially harmful by a lot of people. And so the power to a large extent rests within the biomedical space. And you see that when you speak to the healers as well, where many of them they're encouraged to be connected to people within the biomedical space, because it may lend a certain form of legitimacy to what they do if it is accepted by psychiatrists or by psychiatric nurses or whoever. And that is also it's very common to hear the traditional healers talk about who else they've worked with, and almost always it's about people who work within the biomedical space. Now, in going there to collaborate with the traditional healers, the community mental health workers, or let's say biomedical practitioners in general, must also be very, very cognizant of that power dynamic, because there have been situations where there has been resistance to working with the biomedical professionals. The idea being that they're just there to come and demean what they do, or to make fun of them, or belittle the kinds of influence they have. And these traditional healers are most of the time leaders, cultural leaders within their community. And so the approach that is being used now, that we have started to see, is that they're going there with a clear, with an instruction, so to speak, of not going to demean the authority or the power of the healers that they're working with, making sure you respect their positioning, making sure you respect who they are within those communities, and recognizing that they also bring something to the table. That has been the approach to making sure that there's, to some extent, not so much suspicion or not so much disregard for the work that the healers do. And in fact, some of the people that we spoke with, the community mental health workers, they said it over and over again that we've realized that what they do, we cannot do it, not necessarily. And so we don't go there to demean them. We don't go there to disrespect them. We make sure that we give them the respect that they need or that they desire. Also very useful is the fact that many of the community mental health workers come from those kinds of communities themselves. So they recognize those kinds of things. How do you show elder respect? How do you approach people in an appropriate way? Things like that. Yeah. And so that has been the approach more recently, but there is still quite some resistance. There are still healers who do recognize that most of the time when Western trained people want to work with them, the main focus is on training them. We say that all the time. We need to go and train traditional healers. We need to go and teach them how to recognize illnesses, how to identify or diagnose mental illnesses and things like that. And some of them are not very, they're quite upset with that kind of attitude, because it then isn't a bi-directional relationship. It's more about us trying to change them or to transform them to look more like what we do, to provide service that is very similar to what we do. So it's been about carefully understanding the cultural system, understanding the authority and the positioning of the healers, and recognizing how to harness that, and not necessarily going there to teach them, you need to do it this way, or you need to look out for this and that, and then it means it's depression, or it means it's psychosis, or whatever. But recognizing the kind of expertise that they also bring on board, and working together in that space. So yeah, they do recognize the power dynamics, but it's not always easy to overcome. Yeah.
Thanks, Lee. Neba, I think Neba also has lots of collaboration and historical discussions around imperialistic attitudes of some people when it comes to this issue.
The deficiency we have, it's almost like, say, the factory you come from, you come with all the defects that you find. So there's never emphasis in the training of interprofessional it's always, you're a doctor, you'll find a nurse in the ward, but there's never in the training system that recognizes that. And for me, what I found is the fact is to just realize these people, I mean, they've been practicing for 20, 30 years. They know their trade. You've got to realize that you don't know half of what they know. And it makes you more humble, to be honest. And when you're humble, you are teachable. And more than that, you can teach. But in the process, though, it's that as you are being teachable, they're equally willing to learn from you. So this relationship becomes a two-way. But no, when you come with a holy, I'm big, I'm this, and the response is actually to repel. It doesn't become very much a complementary relationship. So it's kind of a change of mindset. But I'm saying, but there's also lack of emphasis on interprofessional training in the things we do. And so that shows itself in how people work in the field.
Yeah, so thanks. No, sorry, Michelle. I just wanted to maybe move a little bit to Thomas. There's a question here by Craig DeLarge about energy interventions like Reiki being administratable via telemedicine. I thought it'd be an interesting point because of COVID. What has that been like for you in that area?
Yeah, so when COVID happened, so we can do Reiki via distance. We are trained to be able to send the energy. And for one, the purpose of sending Reiki energy is to aid the body's ability to heal itself. And so you're just trying to give the body juice so it can just work in its normal functioning state ultimately. You can do this over distance. I prefer in-person sessions. I just like the conversation in regards to that. I think when you're trying to introduce a art form that doesn't necessarily fit what we've learned in school or in science too much, sending energy from a distance, or what exactly is universal life force energy, right? Those are very big questions. I feel like in person allows someone to just, I think it helps someone understand it a bit better compared to doing it over distance. But we can do distance healing. I've noticed that to be very interesting and effective, and people still will walk away feeling more relaxed and feeling more at ease. So it's possible, but that has been a challenge. I've recently started doing more in-person visits, being vaccinated, and really pushing for patients to get vaccinated as well. And so it's been easier to do it now. But prior to that, I was really doing it via distance, which requires more visualization and more meditation involved for the practitioner. But it still works just as well, which is interesting. Obviously, at least a lot of other questions, and I do have an interest in understanding the how behind things, but that's just something that we're working through, and I find it pretty interesting as a practice itself.
Thank you, Thomas. Maybe you can also, I don't know, think people were asking a little bit about just like psychosis or mania,
right?
Or intergenerational trauma. And so really thinking it looks like more symptom and diagnostically, and then sort of which direction do you go? I don't know if you can speak to that a little bit as well.
For sure, because I've been in private practice for 2 years. It's been 2 years of making this safe space for people to have different theories behind what's going on with them. And so I've had a number of patients who felt like they were experiencing a spiritual awakening experience in their lives that also resulted in being psychiatrically hospitalized. And so, I'm talking to them about just a standard psychiatric assessment, but I'm also leaving space to understand that, okay, some people are stating that they're they believe that they lived before. And there's millions of people who believe in that, and where do you cross the line? I mean, usually if you're not sleeping well, if you're not eating, you're under intense emotional distress, you're not focusing, those are symptoms that can be treated within psychiatry. Now, how the symptoms started, that can be a different conversation, but it still leads to the fact that, okay, there are some neurochemical changes in your brain taking place that are obviously leading to these symptoms, that you're working through. And so I am noticing that people are having different ways in which they're describing their experience through their psychiatric symptoms or in relation to an experience that they're having that they consider to be spiritual in nature. Oftentimes it may not change the end result of how I'm going to treat it, but I do allow space for someone to describe it. But it just depends. I've met people who, this is just a straightforward manic episode. This is a psychotic episode. The history is here, the family history is here. And so getting the data will definitely help to tease it out. But I've also worked with people who, it didn't exactly match everything in DSM, that they were in fact experiencing things that led to intense emotional distress that needed to be treated under mental health. But how that originated and how it's really being integrated in their life and their background, it looks like something else. And so there is space there for some interpretation of the how did it get to this point, and how this person is going to stabilize themselves could be a combination of medication management, talking to a therapist, working with a Reiki practitioner, engaging in divination occasionally, all for the, dietary changes, being physically active. Those are things that can make someone feel really complete as far as an aim in their treatment. But I am seeing that those differences, ultimately, it's really nice to have the background in psychiatry, to have the background in understanding how to treat symptoms, and ultimately, okay, what are warning signs here that regardless of how you're explaining what's happening here, if this continues, you're going to have a hard time functioning. And so having that anchor, I feel like is extremely useful. It's allowed me to engage in those conversations and not get lost in it, because I'm like, well, you have insomnia, I mean, whatever is happening, causing insomnia, okay, but you have insomnia, we need to take care of that. And that's been very useful.
Thank you. Alvin, I'm going to go to you next. And thinking a little bit more about, it sounds like there's a division, right, responsible for the complementary medicine in Liberia. And so what does a foreign traditional healer need to do to be able to practice in Liberia? Is there sort of a list of herbs that people are allowed to use? Like, how does that process and policy work?
As a foreign person that desire of practicing in Liberia, once you come to the office, you tell us what to do, you give us some documentation, what you've been doing. And once you tell, we see what you have, you tell what you can do, we assess your capacity, and then we can give you the license. But the thing is, sometimes, traditional practice is somehow difficult to regulate, because like say it has this cultural link. Some of these people come in and they even practice for long, and then because in recent times they see invisibility of a regulatory body, announcement on radio talking about illegal practice. So before they come in, sometimes people practice for many years without even being recognized or being given legal status. So if there are some people who import supplement, you bring it, we have, because for us, the complementary board or division, we don't have laboratory right now, but you have the Liberia Medicine and Health Product Regulatory Body. Liberia Medicine and Health Product Regulatory Body that is responsible to do testing of all pharmaceuticals. So they can take the product there, we send them there for testing and registration, but at the same time, we are aware of what they are doing. So we in the LMHRA, we work together to ensure that whatever is imported for whatever purpose, under the name of supplement or traditional or herbal product, make sure it is safe for public consumption. Yeah, but before you put it in the market, it has to be tested, it has to be registered.
Okay. Thank you. And we had a comment, it seems like from one of the attendees, saying that there are many Western trained health professionals in South Africa. like nurses and medical doctors practicing as traditional healers in South Africa. So I don't know if Niba can comment on that. And Niba, I'm gonna throw another question at you too, because I don't know if you know, the tech question, one was to Thomas, but another one was just more global around, are there any digital tech enabled delivery traditions of African medicine as well on the continent? I don't know if you know of any.
Not, not specifically any purpose designed tech, but things like cell phone, Facebook are being utilized for consulting in particular, especially during COVID. It became even much more popular. Even those who are into divination, they would use Facebook to discuss dreams, analyze dreams, in supporting each other. But of course, there is, it's more like a courier service that people would deliver herbs, prepared medicines, and deliver them. There's a supply chain into pharmacies and big retail stores that are doing that. So it's evolving, but yet in South Africa, our regulatory process is still going at very snail pace. I think what's happening in the market, you might call it the market, is much more faster, it's much more advanced than the regulators are following behind. That's what I can say. As far as numbers are concerned, yes, almost every day in South Africa, there will be a traditional healer graduating. It's a community-based system. It's an indigenous way. They would always outnumber Western-trained health professionals in general. And there's also actually professionals like Thomas, who's a trained psychiatrist, but also practicing traditional medicine. So there are those who are practicing both. But generally, because traditional medicine isn't yet regulated, they kind of practice it privately, if you want to call it. In the day, they work their normal job, and when they go home, they will then practice traditional medicine. There is still that. What there's been a lot of focus on in South Africa is around primary healthcare. To say there's a way we can integrate at a community level, at a primary level, to find ways to integrate traditional health practitioners. And the orientation of the Department in South Africa of Health is pushing the primary healthcare policy, the primary healthcare approach. It's difficult because they're shifting from a curative system. So it's a big shift that needs to happen. But it looks like traditional health practice can be accommodated much more better at that level. At the ward in South Africa, we're using an approach of a local government and based in wards as a unit of work, where then the ward-based team, including community healthcare workers and other teams, you could easily integrate traditional health practice in that. So that is a policy discussion, but it looks like it's a bit favored approach.
So yeah, thank you so much, Neva, and thank you so much, colleagues. I just wanted to have two things to say. I think the last comment from Nasima on the Q&A, I think is important because we are definitely seeing an increasing number of medical doctors, psychiatrists, nurses, psychologists, clinical psychologists who then get a calling to become healers in our country. And I know Professor Nhlanhla Mkhize, who's one of the senior psychologists at UKZN, has been trying to write about this and to see what that means. Because if you're already registered as a clinical psychologist, then how do you then negotiate that space where the council kind of gives you license to treat and heal people using, psychological sort of therapies, and now you become a healer, etc. So I think that's something that one should probably discuss further and see how one negotiates those spaces. And then lastly, Michelle, before I hand over back to you, I wanted to mention that, for example, there are studies that have looked at collaboration. I think one of the questions was what would that look like? So for example, Professor Oye Gureje in Nigeria has published a really interesting cluster randomized trial where there was integration or collaboration between traditional healers and psychiatrists in a certain region of Ibadan, or a cluster or a district of Ibadan, and showed that with that collaboration, they were able to decrease duration of untreated psychosis. So these are psychotic young people, first onset psychosis, were able to, with that kind of collaboration, we're able to get biomedical psychiatric care much better in that district where there was collaboration versus in other districts in Ibadan where there was no collaboration. So there are people that are already writing about these things, and they are doing studies to kind of describe what they look like. And so hopefully, yeah, future seminars, we could unpack that even further, even more. So thank you very much. And over to you, Michelle.
Over to me. I'm just going to close it out and say thank you to everyone, Drs. Oden, Galeni, Poby, and Alvin, for your expertise today. I think it was very insightful, and there were lots of questions. One of our webinars has lots of questions. So I know you haven't been on all of them, but this was really good. And so obviously there's a lot of interest in this, and how do we bring how do we bring traditional healing into our practices as mental health practitioners? And you gave us lots of insights into how we do that better. And I think that also goes back to that notion of being patient-centered and meeting people where they are ultimately. And this is just something else that each of us should have in our toolbox if we really want to get people the care they need when they need it. So with that, thanks to everybody who attended as well. And be on the lookout for emails from AGMHI on our next webinar. Many, many thanks. Have a great day.
Cheers.
Thank you. Bye-bye.
Bye.